Thank you for the organizers for this invitation. And I must thank Dr. Jaya for that excellent session. I think the invisible pillars do an excellent job, and I think we as clinicians and our patients are very, very indebted to them. So thank you for that. Coming back to, again, medicine, I have to talk about significant surgical abstracts that were presented in this year. First, we will start with the HIPEC trial, the Korean trial, which was published this year in JAMA. The aim was to determine whether HIPEC had any clinical benefit, both in the primary as well as interval setting in advanced ovarian cancer. So this was basically a single-blinded phase 3 randomized control trial between 2010 to 2016, and the patients were followed up till February 2020. There were about 184 patients included in the study. The criteria of complete cytoreduction was CC1 and not CC0. So it was only less than 1 centimeters were all considered as optimally cytoreduced. There was 1:1 randomization between the HIPEC arm and the control arm. Technique of HIPEC which was used was, this drug used was cisplatin, very similar to the Vandrel study. And it was given for 90 minutes, and the temperature was around 41.5 degree temperature. There was also a subgroup analysis which was planned in the trial right from the start between a primary cytoreductive surgery group and an interval cytoreductive surgery group. About 107 patients in the primary cytoreduction arm and about 77 patients in the interval cytoreduction arm. Another, you can say, caveat of the trial was the endpoint was progression-free survival and not overall survival. Overall survival was a secondary endpoint, and obviously adverse events was another secondary endpoint. So this is the trial design showing whatever I have said. So out of total 274 patients who were enrolled, 184 patients were randomized. There was an intra-op randomization after you achieved optimal cytoreduction. Coming to results, now across the group, the median progression-free survival was 18.8 months in the control arm and about 20 months in the HIPEC group. The median overall survival was around 61 months in the control group and about 69 months in the HIPEC group. So overall, you can see there is no difference between the two curves. This was across, included both the primary cytoreduction arm as well as the secondary, as well as the interval cytoreduction group. Now, in the subgroup analysis, if you look at the data from the interval cytoreduction surgery, the mean PFS was 15.4 months in the control group and 17.4 months in the HIPEC group, and the median overall survival was 48.2 months in the control and about 61.8% 8 months in the HIPEC group. In the subgroup of primary cytoreductive surgery, the mean PFS was inferior in the HIPEC arm as compared to the control arm. The overall survival has still not reached in the control group, and it was around 71 months in the HIPEC group. As expected, the adverse events were more in the HIPEC arm. So if you look at this, in the primary cytoreduction subgroup, though the number of patients is less, there was no difference between the HIPEC and the non-HIPEC group. But in the interval cytoreduction group, statistically, there was a survival advantage with the HIPEC arm. This is very similar to what Vandrel study has, the Dutch trial has stated. To conclude, we know that if you look at the overall group, addition of HIPEC to cytoreductive surgery in ovarian cancer did not improve PFS as well as overall survival in patients with advanced epithelial ovarian cancer. Though for interval setting, it did improve PFS and overall survival. It is very important for us to know that in the primary setting, there is still no randomized evidence for us to offer HIPEC to our patients. There is still one trial, OVPEC, which results are still expected. So in the interval setting, you can offer HIPEC to patients, but provided you achieve optimal cytoreduction. Coming to the second abstract, this is secondary cytoreductive surgery for recurrent low-grade serous ovarian cancer, since rare histologies is a theme of this conference. So there is a lot of data on high-grade serous cancers, but we don't have much data on low-grade serous cancers. So, and probably because the number of cases are quite less. So the aim of the study was to study the impact of secondary cytoreductive surgery and residual disease on the PFS and the overall survival in low-grade serous ovarian cancers. Because the number of cases are less, this was essentially a systematic review and a meta-analysis. There were total about 7,600 studies, out of which in the database, but only 9 studies could be included in the final analysis. So coming to the results, very expected visible residual disease after secondary cytoreductive surgery did impact PFS. In secondary cytoreductive surgery with no residual disease, you had a significant improvement in the overall survival in the recurrent low-grade serous. This is also according to the expectant line. Now, what is important is secondary cytoreductive surgery as an initial treatment for recurrent low-grade serous cancers was associated with superior survival in comparison to chemotherapy. What was surprising from this is very different from what we get in high-grade serous. If you have a shorter platinum-free interval, it was not associated with worse survival. Unlike in high-grade serous, a short platinum interval is always associated with poorer prognosis. So it's important that to conclude, complete secondary cytoreductive surgery is always associated with improved PFS and OS in the recurrent low-grade serous cancers, and upfront secondary cytoreductive surgery is a better initial treatment strategy than giving chemo, something like a neoadjuvant chemo and then operating for recurrent low-grade serous cancers. And patients with recurrent low-grade serous cancer should definitely be evaluated for the role of secondary cytoreduction on disease distribution. The platinum-free interval should not be the deciding factor while offering patients to offering secondary cytoreductive surgery to recurrent low-grade serous cancers, unlike the high-grade serous tumors. Third abstract is from TMH, and this is a very practice-changing abstract, and that's why I have selected this. The study was done at Tata Memorial Center. The aim was to evaluate the diagnostic performance and the utility of PET-CT and CT scan for detection of pelvic and para-aortic lymph node metastasis. It's very important to know that since the PET-CT has come in the outside world, PET-CT is like considered as the gold standard for most of the oncological imaging. We need to know that in gynecological cancers, there is still very few indications where PET-CT has an benefit over MRI and CT. So this study was just done to prove it. It included FIGO, the old classification, that is a 2009 staging. 1B1 and 1B2 CA cervix cervical cancers were selected who underwent a preoperative PET-CT as well as a CT scan abdomen pelvis. During surgery, all of them underwent surgery. During surgery, all the lymphadenectomy was done, and the lymph nodes were labeled in separate areas like obturator, external interiliac, and the sensitivity of specificity were estimated for each lymph node station and for all lymph nodes combined as well per patient. Mean tumor was around 3 centimeter and majority of cases were 1B1. The nodal harvest was quite good, around 24 was the average, and it's important to know that the node positivity rate was around 22%, which is corresponding with the historical data. At patient level, all the lymph node stations, the sensitivity and the specificity of PET-CT and CT scan was around just in the range of 53.9% for the PET-CT, and CT scan was around 69%. The primary, it is important to know that the SUV is the most important, is the only independent prognostic factor for overall survival. Both these, you need to know that both these modalities have a very high false negative results with PET-CT and CT, especially in imaging of the para-aortic lymph node metastasis, and you can undertreat these patients. It's important to know that the PET-CT does not have superior clinical utility over a standard conventional contrast enhanced CT scan in choosing what is the best treatment for your patients. If cost is not a factor, then the best imaging for clinically early stage patients might be a combination of PET-CT and CT scan or an MRI. So to conclude, the sensitivity of PET-CT and CT scan for lymph node staging in operable cervical cancer is around 60%, and it is not that PET-CT has better sensitivity than the CT scan for early operable cancers. Both of them have very high specificity provided they are read by expert radiologists and nuclear medicine consultants. Coming to the fourth abstract, which is the TOTEM study, which looked at effectiveness of intensive versus minimalistic follow-up in the treatment of endometrial cancers. This was a randomized, pragmatic randomized trial, mainly done in Italy and France in 42 hospitals, and the patients were divided into two groups. One was the intensive follow-up and one was the minimalistic follow-up. This is very similar to the Gordon-Weston's trial in ovarian cancers. So total there were around 1,871 patients randomized between 2008 to 2018, and they were followed up for a good time of nearly 69 months, and majority of them were low risk cases, 60% were low risk cases, and they were matched in all the other groups. And so in the intention to treat in the patients where there was an intensive follow-up done, though the relapses were detected, but early detection did not translate into overall survival improvements. And so to conclude, an intensive follow-up in the endometrial cancer treated patients did not improve survival. So you are detecting patients early, but it did not make a difference in the survival. And this trial concluded there was no role of adding routine vaginal cytology, laboratory or imaging investigations in asymptomatic, non-clinically detected relapse patients. Coming to the fifth abstract, which looked at whether a primary a unilateral inguinofemoral lymphadenectomy in patients with early stage vulval cancers and a unilateral metastatic sentinel lymph node was safe. So in this study, what they did is, there are two large studies, the groins 1 and 2. The data from these groins, which are probably the largest evidence that we have on sentinel nodes for vulval cancers, they were analyzed, and all patients with a unilateral metastatic sentinel lymph node were selected. The incidence of contralateral additional non-sentinel metastasis in patients with a unilateral sentinel lymph node metastasis who underwent a bilateral inguinofemoral lymphadenectomy was determined. In those who underwent only an ipsilateral groin treatment or no further treatment, the incidence of contralateral groin recurrences during follow-up was determined. Now, total there were around 1,900 patients, out of which 366 had a unilateral metastatic sentinel nodes, and out of that 244 had a inguinofemoral lymphadenectomy or no treatment of the contralateral groin. So there were total 7 patients, that is 2.9% patients with a contralateral non-sentinel lymph node metastasis or groin recurrences were observed. This was very comparable to the false negative rate in the groin study, so this was quite accepted. And it's important to know that the risk is much higher in tumors which are more than 3 centimeter. So in 3 centimeter you cannot omit the other side groin lymph node dissection. What's important, what was surprising in this study, that the tumor location on the vulva, whether it was a lateralized tumor or a near midline or a true midline, had no influence on survival. And you should consider performing a unilateral inguinofemoral lymphadenectomy or a inguinofemoral radiotherapy alone in patients with a unilateral metastatic sentinel node, and you should always exercise caution in patients with larger tumors because majority recurrences were in tumors which were more than 3 centimeter. This is my last abstract. This was basically an integrated analysis of cervical squamous cell carcinoma cohorts from 3 continents, and they looked at an interesting where squamous cervical carcinoma was classified into 2 subtypes. The majority patients were from US, Europe and the sub-Saharan African, and this trial said that this was basically a genomic analysis of around 643 cervical squamous cell carcinomas, and they classified the cervical cancer into 2 subtypes, which is C1 and C2 with differing prognosis. So in this you just need to know that the 5-year survival was very different between the 2 subtypes. The C2 subgroup is supposed to be more aggressive and with a worse prognosis than the C1 subtype. I thank you for a patient hearing. Thank you.